Hello and welcome to your OB course. Today we're going to be talking about some things related to fetal heart rate monitoring. This is part one of two different presentations. When trying to understand fetal monitoring, it's important that we understand the definition of different terminology. The terminology or the lingo utilized in obstetrics is very different from that which is used in other classes like med-surg or pediatrics. Okay, this is very specific. OB is a specialty, and therefore there's a lot of new terminology that you must learn. Okay, here I have a list of the different words that you need to understand. It is imperative that you know what all these terms mean in order to understand when we review fetal monitoring strips, in order to understand what everything means. So we have baseline fetal heart rate, baseline variability, indeterminate fetal heart rate, accelerations, decelerations, variables, sinusoidal, pseudosinusoidal patterns, tachycardia, bradycardia, normal fetal heart rates, abnormal fetal heart rates, and as it relates to the different categories, okay? And then of course, when we're assessing the uterine contractions, we need to understand what frequency, duration, and strength refer to. And we'll talk about some of these things as we go through this presentation, and the rest will be covered in part two of this fetal monitoring review. So just so that you have a better idea, when we talk about fetal heart monitoring or the interpretation of a fetal strip, when we refer to acceleration, we are talking about the increase or abrupt increase in the heart rate from the baseline. Of course, to understand that there's an increase in heart rate, you must understand what baseline means. Okay, so baseline by definition means that the fetal heart rate is rounded to increments of 5 beats per minute during a 10-minute window, and you must have at least 2 minutes of identifiable baseline segments that do not have to be contiguous, all right? But you have to have at least 2 minutes of baseline in a 10-minute period. Please be reminded, we round up to the nearest 5th beat, whether it's up or down, all right? You are never gonna say fetal heart rate, the baseline of the fetus is 112. No, it's either 115 or 110. It's not gonna be 123, it's gonna be 120 or 125, all right? Never anything that is not a multiple of 5. So here we can see that an abrupt increase in the heart rate from the baseline is what we call an acceleration. It can occur at any time during labor. It is indicative of a well-oxygenated baby. We want to see accelerations in a fetal strip, okay? This is a positive indication that the baby is well oxygenated. Then we have what we call variable decelerations. Variable decelerations are kind of like an acceleration, but in the opposite direction, okay? They're abrupt decreases in heart rate from the baseline, and they recover, they decrease quickly and generally go back up quickly, all right? And the deflection or the deceleration, the variable deceleration, is not related to contractions, okay? It has nothing to do with the contractions. It can occur before the contraction, during the contraction, after the contraction, generally not related. It occurs when we have cord compression, umbilical cord compression. This can happen for many reasons. It could be the fetal lie, the positioning of the baby. It could be that whenever mom moves, she compresses the cord, or it could be the baby's playing with the cord and squeezes it, all right? This does happen. And in these cases, we want to reposition our patient to make sure that cord compression does not occur. A lot of times it does happen because we have decreased amniotic fluid. So when there's very little amniotic fluid or oligohydramnios, we tend to have more variable decelerations. And we'll talk about what we do and how we handle that in OB. Late decelerations, again, are deflections that go below the baseline. But in this case, it occurs, it is related to the contraction, and the deceleration occurs or starts to occur at the peak of the contraction. So as you guys can see here in this picture, the late deceleration, the baby's heart rate starts to drop as the contraction peaks. So at the peak of the contraction, the baby's heart rate starts to drop and then recovers, right? This may be indicative of fetal distress if it is repetitive or severe. Severe means it's really deep and prolonged, lasts for a long period of time. Late decelerations is not something that we want to see. It can be indicative of uteroplacental insufficiency, which means you can't get enough oxygen across the placenta to the baby, right? Again, late decelerations. If I only give you a fetal strip that shows just the fetal heart rate and I cannot see the contractions, you cannot determine if that deceleration is late or early. Because we do have, like you guys saw in my previous slide, what we call early decelerations. With early decelerations, unlike late decelerations, they mirror the contraction. So when the contraction starts to occur, as the contraction peaks or starts going up, as it increases, okay, we find that the baby's heart rate starts to decrease. So it creates kind of like a mirror image, right? And an early deceleration is an expected finding as women progress through labor. So it's not something that we are concerned with. It's not something that requires interventions, except maybe doing a vaginal examination to make sure to see if maybe the patient is crowning. So fetal monitoring, how do we do fetal monitoring? How do we see all of this? There's different types. We have external electronic fetal monitoring, right? And there's different ways that we can assess the fetal well-being. We have what we call a fetal scope, all right? Fetal scope is basically when we auscultate fetal heart tones with a fetal scope, and it allows the provider to hear the sounds, the heart sounds that are associated with the opening and closing of ventricular valves via bone conduction, okay? We can also listen to the fetal heart rate utilizing a Doppler, okay? An ultrasound stethoscope. With a Doppler, it uses sound waves that are deflected from the fetal heart movements, similar to that which is used on an EFM, or an external ultrasound transducer. So with an ultrasound transducer, we know what that means. It's the same thing that they utilize to do ultrasounds, and it basically it listens to the sound waves, all right? And then we have a toco transducer. The toco transducer, or what we call a toco dynamometer, it's like a tongue twister. We measure or assess uterine contractions, okay? It tells us, the toco transducer allows us to see when our patient or client is having a uterine contraction, right? And then we have what we call internal electronic fetal monitoring. And this is something that is utilized on an exception basis, okay? So we generally do external electronic fetal monitoring if we have a patient that is maybe has a lot of adipose tissue and we're not able to hear the fetal heart tones clearly, or it's interrupted frequently, or we're not able to perceive the contractions because they have a lot of abdominal fat or adipose tissue, or because the baby might be in a position that's awkward where you can't really hear the heart rate for many reasons, all right? We will do an internal electronic fetal monitoring, okay? With electronic fetal monitoring, we use an ultrasound device to detect the fetal heart rate and a pressure device that assesses the uterine activity, okay? The fetal heart rate is measured via an ultrasound transducer. And what happens is it's an invasive procedure, okay? In order to do this, number one, your patient's membranes have to be ruptured. So their water has to have broken already, okay? So if a patient is intact or their water didn't break yet, you cannot use internal fetal monitoring. You cannot use a fetal scalp electrode, right? So they have to be ruptured. They have to be generally at least 2 centimeters dilated so that you have access, all right? And they cannot have certain infections. If they have active herpes, you cannot do this. If they have GBS, you cannot do this. If they have chorioamnionitis, you cannot do this. If mom is HIV positive, you cannot do this. So if they have infections, you cannot utilize an internal monitor, a fetal scalp electrode. The IUPC, or intrauterine pressure catheter, is also inserted. It's an invasive procedure. Again, patient must be ruptured and have ideally at least 2 centimeters of dilation. This does measure exactly measures the exact intensity of the contractions, intensity and duration of the contractions. And again, same contraindications as a fetal scalp electrode. And we do this if and only if we are not able to accomplish or get the tracing that we require from an external fetal monitoring. Very important. Anytime that you're taking care of a client, we treat the patient, not the machine. Please don't be afraid to use your hands. Palpate. Your hands tell you a lot. You can use your hands to find out in what position your baby is in. You can use your hands to detect the contractions, to identify the strength, the intensity of the contractions, the duration of the contractions. So it's very important that we learn to use our hands. And here I just have some pictures of what an external monitoring showing the placement of the ultrasound and toco dynamometer looks like. So over here, this is the fundus. This is the top of the uterus. Okay, this is where we put our toco. And then the ultrasound transducer is generally towards the bottom. Remember, the baby's head should be cephalic, ideally. And so generally the ultrasound transducer is below the belly button. It could be on the left, on the right, in the center, depends on the fetal position. In this case, it's right above the symphysis pubis, okay? And it captures the fetal heart rate. With a fetal scalp electrode or internal monitoring, you see here we have a catheter that has to go in through the vagina, okay, inside the uterine cavity, right? This catheter is able to measure the contractions, the duration, the intensity, okay? Again, she has to be ruptured, 2 centimeters dilated. And then over here, what we see, this little thing is the scalp electrode. The scalp electrode, it looks like a little coil that actually goes on the skin of the baby, on the scalp of the baby, and it's able to detect fetal heart rate. It is very accurate, and mom can move around in the bed, and it doesn't affect the tracing. And then I have here auscultation of fetal heart rate, okay? You can detect. The picture at the top shows you a provider who is utilizing a fetal scope, okay, non-electric. It's almost like a stethoscope, but it's utilized to listen to the baby's heart, not mom's, okay? So it's kind of the same thing. It's non-electric, so if we run out of power, batteries, and, you know, we have no technology, we can always use a fetal scope. The picture in the bottom shows a Doppler. Obviously, it utilizes battery, so it's electronic. And it does give you digitally, it'll show you the fetal heart rate. And you kind of have to listen for a little bit and establish a baseline. Please note that when you are auscultating the fetal heart rate, because the patient is not on a continuous monitor, you require one-to-one fetal monitoring, okay, during labor. So because you have to be assessing frequently, and we're going to see some of the parameters and the standards for A1, you generally only have one patient, okay? Palpation, when we talk about using your hands, we have to measure frequency, duration, tone, and intensity of the contractions and can be assessed by palpation. Use your hands. So you touch the top, you know, usually above the belly button, below the symphysis, the xiphoid process, I'm sorry, and you can palpate the contractions, okay? If it's mild, if the contractions are mild, you can easily dent the uterus. And if it's moderate, you can slightly indent the uterus. And if there's strong contractions, you cannot. It'll feel very, very solid almost. It's not indentable. You cannot indent the uterus, or 3+. Okay, so it's important that you know how to use your hands, because if the power goes out and you don't have a monitor, you should, as a provider, as a nurse, should be able to palpate your patient's uterine contractions. Of course, in these cases, you know, you would be one-to-one because it has to be done frequently. Okay, clue to contractions. Can you figure out the duration, intensity, and frequency? That's just a cute little picture to help you remember. A1 standards for frequency for fetal heart rate assessment. For intermittent auscultation, what does that mean? It means the patient is low risk and doesn't have to be on continuous fetal monitoring. Okay, so if she's low risk, during the latent phase, you would assess the heart rate every hour, right? During the active phase, you want to assess heart rate. Remember, active phase is after they're 6 centimeters dilated. So you would want to auscultate or assess the fetal heart rate every 15 to 30 minutes. And then during the second stage of labor, which means your patient is complete and ready to push the baby, you would have to be assessing your patient every 5 to 15 minutes. If your patient is high risk, continuous monitoring is recommended for high risk patients, right? So you leave them the monitor all the time, and you are to come back and document and assess during this latent phase every 30 minutes. Notice how it's half of the time. And then in the active phase, minimum every 15 minutes. And during the second stage, you don't do it every 15, you do it every 5 minutes. Those are the standards for assessment. Okay, if they're on an electronic fetal monitoring, means they're on a monitor all the time. The assessment requirements or frequency is in essence the same, but it just makes your life a lot easier because the machine is monitoring them and you're just documenting and assessing and making sure that everything is going as planned. Now, what influences fetal heart rate? There are several things that can influence fetal heart rate. All right, the uteroplacental unit, okay, how good of a placenta you have. For example, there are women who have hypertension. Women who have chronic or severe hypertension tend to have placentas that are smaller. They don't perfuse as well because of the hypertension. So, that affects the fetal heart rate. Then we have the autonomic nervous system, which includes parasympathetic and sympathetic, baroreceptors, central nervous systems, chemoreceptors, and hormonal regulation. With the parasympathetic nervous system, okay, the parasympathetic stimulation decreases the heart rate. The parasympathetic nervous system is primarily mediated by the vagus nerve, which innervates the SA node and the AV nodes in the heart. So they obviously affect the fetal heart rate. The vagus nerve stimulation slows down the fetal heart rate and it helps to maintain variability. So variability in fetal heart rate develops at 28 to 30 weeks of gestation. This is important to know. All right, prior to 28 weeks gestations, babies will have some variability, but it's not something that gives us a lot of information. There are tests, such as the non-stress test, that look at variability, so we do not do them until our client is at least 28 weeks gestation. With the sympathetic nervous system, okay, it stimulates increases in the fetal heart rate. Okay, so the parasympathetic stimulates a decrease in the heart rate, and the sympathetic stimulates an increase in fetal heart rate. The nerves are distributed widely in the fetal heart, and stimulation produces an increase in strength of the fetal heart contractions. The sympathetic nervous system is responsible for fetal heart rate variability. Actions occur through release of norepinephrine, all right, and the SNS or sympathetic nervous system may be stimulated during hypoxemia. So you'll see a lot of times if a baby becomes hypoxic, they become tachycardic, right? Then we have baroreceptors, which are the stretch receptors in the aortic arch and the carotid arch, which detect pressure changes. They provide a protective homeostatic mechanism for regulating the heart rate, and basically by stimulating a vagal response and decreasing the fetal heart rate, fetal blood pressure, and cardiac output. So this is what baroreceptors do. Then we have the CNS. It's responsible for variations in the fetal heart rate and baseline related to fetal activity. And it coordinates and regulates autonomic activities. It mediates cardiac and vasomotor reflexes and responds to fetal movement. Okay, so it'll increase variability or the heart rate in response to the movement of the baby. Then, of course, we have the chemoreceptors, which are located in the aortic arch and the CNS, and they respond to changes in fetal oxygenation or the levels of O2 and CO2 and the pH level. So when you have a decrease in O2 and an increase in CO2, you have it causes peripheral chemoreceptors to stimulate the vagus nerve or the vagal nerve, and in return they slow down the heart rate. The central chemoreceptors respond to an increased heart rate and an increased blood pressure. And of course, we have hormones, okay? The fetus responds to a decrease in O2 or uteroplacental blood flow by releasing hormones that maximize blood flow to vital organs, such as the heart, the brain, and the adrenals, all right? So when the baby becomes hypoxic or is experiencing some level of hypoxia due to, who knows, uteroplacental insufficiency, maybe maternal positioning, or maybe an abruption, whatever complication is happening, they release hormones that maximize the blood flow, and it sends all the blood to vital organs. So only the brain, the heart, and the adrenals. Epinephrine, norepinephrine, catecholamines, and vasopressin facilitate hemodynamic changes in response to the changes in fetal oxygenation. Okay, so basically when the baby becomes hypoxic, they release epinephrine and norepinephrine. They increase the heart rate and the blood pressure, and in response to the hypoxia. Then we have what we know as fetal reserves, all right? Fetal reserves, placental reserves. They describe the reserve of oxygen that's available to the fetus to be able to withstand transient changes in blood flow and oxygenation during labor. When does this happen? If a mom is having contraction after contraction after contraction, you know, it doesn't really give the baby time to relax and recover. But they do have this placental reserves, which allow them to tolerate labor. Okay, in a healthy maternal fetal unit, okay, the placenta provides oxygen and nutrients beyond the baseline needs of a fetus, which is why they're able to tolerate the labor. When the oxygen is decreased, the blood flow is deferred to vital organs to compensate. And when placental reserves of oxygen are decreased or depleted, the fetus is not able to adapt or tolerate the decrease in oxygen that occurs during a labor contraction. Okay, so here is when we would see on a fetal strip late decelerations. Basically, the baby has already gone through all the placental reserves, and now in response to a contraction, the fetus doesn't tolerate it because it has decreased oxygen, and in a fetal strip, it reflects as a late deceleration. Fetal adaptation to the stresses of labor occur through homeostatic mechanisms, okay? So it's important that we know that when we're having late decelerations, it's basically because there are no fetal reserves, no placental reserves anymore. So what happens is the baby starts to decompensate, which is why when we have recurrent or continuous late decelerations, we generally have to deliver the baby immediately via C-section, or depending on the situation that we're facing. If mom is already complete, we want to make sure that the delivery of the baby happens as quickly as possible. So I hope that this information has spiked your curiosity and that you go back and do a little bit more research. See you next time.